the 13th Annual NORA Symposium and the 12th Annual Paul S. Richards Invited Lecture. This is the opportunity I have to turn the program over to Dr. Kurt Egman, Director of the Rocky Mountain Center, to introduce our speaker.
Thank you very much, Don, and good morning. Thank you for coming. It always gives me a great pleasure to have the opportunity to introduce our invited guest speaker for this keynote address. Dr. Larson will join me up here for just a minute. No, Dr. Larson's not giving your keynote, but hold that thought. Today, it gives us great pleasure to bring here with us to this conference Dr. Rando. Those of you who have been here before may know that this is regarding the Richards Lectureship, and since the slides are not working for me, hopefully they'll work for him. The answer to the question of who is Dr. Richards, for those of you who are not familiar, Dr. Richards was actually raised in Salt Lake City, educated in Harvard, came back, and those not too familiar with the Valley, though, could step out the door and see what is been and is the valuable mine in the history of the world across the valley here, the Kennecott mine. He came here, went there for 6 months to take care of the workers, and stayed for most of a career. In the process, found all sorts of problems and had huge impacts, a few of which are in this slide, some of which indeed are respiratory related, not surprising, considering that the mine initially actually was an underground mine before it went above ground. A lot of problems with silicosis, anything from safety and so forth. And so Dr. Richards' impacts ultimately led to the development of an endowed chair here at the University of Utah, which I'm honored to hold. But more importantly, much more importantly, to impacts that continue to the current time in terms of safety of workers from the standpoint of both injury, illness, accidents, and disease. We are bringing Dr. Rando here from Tulane University. Dr. Rando is a professor in the Department of Global Environmental Health Sciences. His research interests include the etiology and epidemiology of occupational environmental lung disease, and also characteristics of exposure assessment and industrial hygiene chemistry. He's got many positions, including, besides being a certified industrial hygienist, but editorial board for the Journal of Occupational Environmental Hygiene, and numerous other things, too many to mention. He's had dozens of publications of high impact, and Dr. Larson would like to say an additional comment.
Yes, good morning. I just want to take an extra 30 seconds and point out that Dr. Rando, and it's my pleasure to have met him yesterday. I've knew him previously by phone calls and emails. He has been awarded the first award called the Impact Award from the American Board of Industrial Hygiene. All the industrial hygienists know what that is. That's the board that gives you the certification if you earn it, and then you have to maintain it with their rules. But this Impact Award, the nominees that are produced or nominated for this award have to have shown a strong impact in the field of industrial hygiene, both in the depth and breadth of their research. And looking at Dr. Rando's work, he definitely qualified, and ABI has agreed and gave him the first Impact Award. With that,
Dr. Rando, please come up. We do have a plaque to commemorate this. I'm sure Dr. Blaswick, Dr. Blaswick's normal self, will take a photo later.
Right.
Thank you. This is to commemorate, so we'll weigh down your luggage a little bit.
Okay.
And,
No, that's
and we
wonderful.
really appreciate you coming up from New Orleans and being with us today.
Thank you very much.
Thank you.
Thank you. Well, thank you all very much for inviting me to come here and share some of our work with you today in honor of Dr. Richards. During the introduction, when Kurt was talking about Dr. Richards, I found it somewhat ironic. Currently, one of the things that we're working on is an epidemiologic study of silicosis in industrial sand workers. Doing that with some colleagues at the University of West Virginia and the University of Vermont. And so we're almost 100 years later after Dr. Richards, and we're still talking about silicosis in this country. So I know that's a very important issue right now, especially with the boom in the fracking industry, which uses extremely large quantities of industrial sand. But today, specifically, I want to talk with you and share with you the results of some of our research looking at respiratory health and exposure and restoration work in the post-Katrina environment. And so, let's make sure I get this right. Nope. Got it. Okay. So one of the main issues that we were concerned about in terms of doing restoration work after Katrina was exposure to bioaerosols. And as I'm sure most of you know, there's been quite a bit of interest in the last few decades related to exposures to moldy environments and potential impacts on health. The WHO sort of summarized the evidence out there, came to some conclusions regarding health effects and exposure to damp environments and moldy environments. And they determined that there was sufficient epidemiologic evidence to link damp and moldy buildings with increased risk of respiratory symptoms, infections, and exacerbation of asthma. Some evidence also they found of increased risk for allergic rhinitis and asthma, or new onset asthma. They also found there was clinical evidence linking these sorts of buildings and environments with some less common respiratory diseases such as chronic rhinosinusitis and hypersensitivity pneumonitis. And then there was also toxicological evidence showing that exposure to microbes and their components isolated from these sorts of environments induced respiratory inflammation and other responses in animal models. So when we think of looking at damp, moldy environments, flood events sort of provide us extreme examples of these sorts of environments. And flood events, unfortunately, are very common, have been for a long time in this country and elsewhere in the world. This is just a listing I pulled from the FEMA website showing some of the major flood events in this country in the last 10 to 15 years or so. And a lot of these, of course, were tropical cyclone events, hurricanes and tropical storms. But if we look at let's see. If we look at the amount of payouts from claims, damage claims, shown in this column here, you can see that Hurricane Katrina really stands out as being a very special event, unfortunately, in the history of this country. Payout, according to FEMA, $16 billion, and even if you compare that to Superstorm Sandy, which was another major flood event, it's about twice as much as in terms of payouts as what was associated with Superstorm Sandy. So, in a sense, Hurricane Katrina is really a benchmark when we look at flood disasters, and for our purposes, of course, right in our neighborhood, it was certainly a fertile ground to do some research and try to answer some questions about the risk associated with flood restoration work. So Hurricane Katrina sort of devastated South Louisiana, southwest Mississippi rather, in August of 2005. And then we got a double whammy with Hurricane Rita about a month later, which came in a little further. This is the track of Hurricane Katrina. And by the way, when people in my area of the country see a picture like this, we get real nervous. Extremely well-defined, very large storm, perfect eye. When we see that, we head north. And I actually headed west and evacuated to Houston during the hurricane. But Hurricane Katrina and Rita devastated about 90,000 square miles of territory, equivalent to the area of Great Britain. Over 1 million people evacuated. There were almost 2,000 deaths associated with Hurricane Katrina, quite a few in the city of New Orleans due to drowning. About 80% of the city of New Orleans was flooded. Only areas of New Orleans that did not flood were those the narrow band right along the river, because that's a natural levee, geologic levee, if you will, including the French Quarter, and that's the highest ground in the area. Obviously, that's why the settlers started the city of New Orleans in the French Quarter, because it was high ground on a natural levee. But as you move away from the river, the ground, the ground actually goes below sea level, and because of that, the entire city, metropolitan area, is ringed by a levee system, man-made levee system, and rainwater and so forth has to be pumped out. It doesn't naturally drain because we're below sea level. And that was part of the issue that caused a major problem here, is that when the tidal surge breached the levees in New Orleans, that floodwater was trapped after the storm passed. It can't drain out naturally. The pumping stations were inoperable. And so those floodwaters stayed in place for many weeks until the Army Corps of Engineers could build in some emergency pumping capacity and start draining that water. It was 43 days, to be exact, before the Army Corps of Engineers could remove all the flood water from the city. This is actually a picture of my research building. Right shortly after the hurricane. I didn't take the picture, I was gone. But my office is right about here. We're on a relatively high part of the city because we're somewhat close to the river. So we had a couple of feet of water in the building itself. And here's an interesting picture. This picture is from an area of the city called Gentilly, if any of you are familiar with it. But what you can see, interestingly, is the multiple water lines on the side of this house. Again, water came in, couldn't escape. It would drop down a little bit over time and come back up again. This happened repeatedly over a period of about 3 weeks. And so you see these multiple water lines. And here are some photographs just to give you, I mean, it's really hard to describe the level of devastation with a few pictures, but anyway, just to give you a sense of what it was like. This in particular was a trash collection area. The pile's probably about 25 feet high. It was about 75 yards wide and about maybe a quarter of a mile long. All the debris that was being collected was being brought here as a temporary holding area until it could be disposed of. Here you have a fellow working on remediating his own home. He has a filtering face piece on, at least. So, again, our main concern here was the presence of bioaerosols and flood-contaminated debris, and how this material could become airborne during restoration work and result in exposures of workers in individuals doing remediation and restoration work. So there were issues, concerns with both bacteria and mold and fungi. We focused on measuring markers of these microorganisms, specifically endotoxin for gram-negative bacteria and 1316 beta D-glucan for mold. Both of these materials are pro-inflammatory agents themselves, and in particular endotoxin, well-known respiratory toxic agent associated with the development of toxic pneumonitis and organic dust toxic syndrome. Shortly after Katrina, various research groups got in and started doing measurements and so forth. So this is an excerpt from a paper by Riggs and et al., in which they looked at endotoxin levels and glucans inside of flood-damaged homes in New Orleans. And they found some clear correlations with increased endotoxin and glucan levels associated with flood level, for example. If there was more than 3 feet of water in the home, the levels were elevated in comparison to those homes where the water levels were less than 3 feet. Mold coverage on the walls, interestingly, not so much of a correlation. Wall materials, plaster. A lot of the older homes in the New Orleans area have plaster walls, and plaster is not such a good substrate for these microorganisms. The drywall, on the other hand, the paper lining on the drywall, the mold organisms just love that stuff and colonize it and so forth. So these levels of endotoxin also are about an order of magnitude or so greater than what we would typically find in a non-flood damaged home. So. Another paper by Ginger Chu, who was at the Columbia School of Public Health at the time, interestingly looked at the effect of remediation work on levels of microorganisms and endotoxin. And you can see, for example, for endotoxin here, Ginger was able to sample 3 homes, and so she got baseline measurements on endotoxin levels while there was no activity going on in the homes. The gray bar is the outdoor levels. So you can see the indoor levels are an order of magnitude or so greater than the outdoor levels, and quite elevated anyway, pushing 100 endotoxin units per cubic meter, which is quite a high level, and approaching recommended occupational exposure limits. Now, when remediation work actually started on the homes, you can see a dramatic increase in the level of endotoxin in these same homes. In particular, you can see home number 2 here, the white bar, around 2,000 to 3,000 endotoxin units per cubic meter during the remediation work. She also saw increases in colony-forming units and equivalent spore counts through PCR analysis. In addition, there was some work early on actual or potential health effects associated with exposure to materials from the flood damaged properties in New Orleans and surrounding areas. This is excerpted from a paper by Wang et al. In this paper, the researchers collected sediment from the area after the flood. One of the things we saw after the flood event was there was a layer of deposited sediment everywhere once the flood waters receded. Roads, lawns, everything was covered with this sediment material. So they collected samples of this sediment and exposed mice to the sediment material by installation. And they found several interesting things. They saw an increase in airway reactivity and airways resistance in the mice who were exposed to the sediment material. That's the red lines here. This is pen, and this is specific airway resistance. The black line, dotted line, is the saline control. So they showed increased airway hyperreactivity following exposure to the sediment material in mice. And the other thing they saw was pretty obvious evidence of induced inflammation in the lungs of these mice after exposure to the sediment material as well, with an influx of neutrophils in the bronchoalveolar lavage of these animals after the exposure to the sediment material. So there's pretty strong evidence that this stuff, which was a mishmash of all sorts of things, including microbials, but also petroleum residues, natural soils, some heavy metals, you name it. There's all kinds of stuff in that flood water. Clearly had some significant effects, potential effects on respiratory health if inhaled. NIOSH also got into the area early on and did a small survey of first responders, firefighters in particular, who were in place, didn't evacuate, and had varying levels of exposure to the floodwaters in the few weeks after Hurricane Katrina. And they administered a questionnaire to these firefighters who participated in the study, asking about respiratory and skin conditions. And this was published by Tak et al. In American Journal of Industrial Medicine in 2007. And I have here excerpted the respiratory part of the analysis. And you can see for upper respiratory systems, which included head and sinus congestion and nose or throat irritation, lower respiratory systems, symptoms which included shortness of breath, wheezing, chest tightness, and cough, both productive and non-productive cough. For all three of these general indicators of respiratory health, there were obvious and significant increases in the prevalence associated with increasing exposure to the floodwaters. So you can see this sort of qualitative exposure scale, the top is the highest exposure level. So these folks here would have had skin, nose or mouth or eye contact with floodwaters for longer than a few hours total. That was the majority of them actually. And you can see the prevalence for upper respiratory systems, lower respiratory systems, and cough is highest for all the exposure categories. And there's a consistent trend for all three of these measures as you move from no contact with floodwater up until increasing contact. So again, a preliminary indication of some potential adverse impact on respiratory health associated with being in this environment after Katrina. The other issue that appeared initially anecdotally was something that became known as Katrina Cough. And this was sort of a symptom complex that was apparently being commonly reported among the population in New Orleans after Katrina. The primary markers of the syndrome were a persistent, non-productive, dry cough. And of course the news media gets a hold of this sort of thing and they put the moniker on it, Katrina Cough. Often accompanied by sore throat, runny nose, and so forth also. Ultimately, there's been a consensus developed that it was primarily an irritant phenomenon associated with the high particulate levels generally in the environment after Katrina. Part of that, again, was due to the sediment that was deposited and all the work that was going on you know, trucks and vehicles traveling on the streets and so forth, constantly kicking this material up. And so there was generally a high particulate load in the atmosphere in the few months after Katrina. In addition, after Katrina, we actually had a fairly dry fall. And so that exacerbated the airborne dust problem. And we have a normal allergy season that begins in the fall in New Orleans also. So Katrina cough, whatever it was probably related to these things. The Louisiana Office of Public Health, the state Office of Public Health, did a survey of people reporting to emergency rooms with symptoms consistent with Katrina cough, and compared them to emergency room visitors who did not have those particular symptoms. And this is an excerpt from the report that the OPH produced. And for the most part, there's nothing there. In terms of comparing the cases, the so-called Katrina cough cases versus the controls, basically there weren't any differences between the two groups. And that includes things like, you know, living in flood-damaged homes, living in a moldy house, construction jobs, debris jobs, mold jobs, remediation jobs, so forth. Okay? So none of these things were really statistically significant between the cases and the controls. The only thing that showed up was the work with debris, adults working with debris. One of the major limitations of the study, in any case, was the fact that it was focused on emergency room visits. So that represents a pretty extreme case of Katrina cough. Most of the Katrina cough was a fairly innocuous variety, persistent perhaps and chronic, but not particularly overwhelming to individuals, and to drive someone to the emergency room because of that probably indicated something else besides Katrina cough, at least in my view. So, because of all these issues, we had a real concern about, you know, the restoration workers who came in, or those who returned to New Orleans after the event. The fact that they would be exposed to these materials that apparently have some respiratory toxicity associated with them, according to the animal models and according to the early survey work and so forth. And then there was the issue of Katrina cough as well. And so we, my research group that is, put together a proposal submitted to NIOSH to do a study of these restoration workers, looking at their respiratory health. And I can tell you that was a very challenging experience. All of us in the research group were in diaspora. I was in Baton Rouge. The principal investigator was in Houston. Some of the other folks were in San Antonio and Atlanta. And so we were all communicating by email and everything, trying to put together a proposal to be submitted in October of 2005. And we managed to do that. And so we got a proposal submitted. And Sid's gone, so I can say this. So the way NIOSH works, you know, it takes a little time to get things going, if you're successful. So ultimately, we were successful in getting funded from NIOSH to do this study, but we weren't able to start until the fall of 2007. So basically, we missed the juiciest 2 years of the entire process, unfortunately, but that's the nature of this business we're in. So the two-lane post-Katrina worker study, our objective was to investigate the association between exposures during restoration work and potential adverse respiratory impacts, including respiratory symptoms, exacerbation and development of asthma, bronchitis, pneumonia, hypersensitivity pneumonitis, toxic pneumonitis, that's TP or organic dust toxic syndrome, sometimes known as also, and also excess decline in lung function longitudinally. Okay? So the study design was a 5-year longitudinal cohort study. Again, started in 2007, went through 2012. And we also did a cross-sectional evaluation of respiratory health in these folks and an assessment of annual change in lung function over the 5-year period. So our target was to recruit about 1,000 people from the New Orleans area, adults, who were involved in restoration work. So they were mostly in the construction industry, building trades, custodial workers, and so forth. And we recruited the population from a couple of sources. We had 2 large academic institutions in the city who participated, and 1 large local branch of government allowed us access to their employees as well. All 3 of these institutions had in-house staff that were involved in restoration work, their normal facility services folks and so forth. But they also brought in contractors to help because the work was just overwhelming at that time. In addition to those 3 large institutions, we also accessed local building trade union for their members to participate. And we also went to various building products retail outlets like Home Depot and Lowe's in the area, and parked our mobile laboratory in their parking lot with their permission, and set up shop and invited workers to come in and participate in the study. And there was tremendous traffic in those early days. Contractors went constantly in and out of those places. Okay. The study participants were issued a standardized questionnaire evaluating potential for exposure, respiratory health, symptoms, and so forth, demographics, the usual things. And we did standardized spirometry, quality controlled and assured to meet the ATS criteria. Collected smoking history, obviously. And then we also administered a separate questionnaire on their restoration work activity up to the point of interview, post-Katrina. And we focused on 5 specific activities associated with restoration work. That included demolition, trash removal or management, landscape restoration, sewer and water line repair, and actual mold remediation. Okay. And also we performed an exposure assessment at the time of the visit, collecting personal samples for thoracic particulate matter, which were then assayed for endotoxin and beta-glucan. This is just a photograph of the mobile testing laboratory that we used. The interior is the spirometer here. This is actually me, and this was our workstation for the exposure monitoring part of the process. We ended up, over the course of the study, with 898 participants, so pretty close to our target of 1,000. About half of them were involved in what we think of as trades or jobs associated with restoration work directly, such as carpenters and electricians, plumbing, painters and drywall workers, HVAC technicians, groundskeepers, general construction workers, general maintenance workers, building and operating engineers, mechanics, and then custodial and janitorial workers. Okay. The other category included clerical and management staff from the facilities services departments in the institutions and so forth. So we included them as well if they were willing to participate. You know, as it turned out, a lot of those people you normally think of as controls were also involved in remediation and restoration work of their own properties. And so when we did the exposure survey in terms of how much time have you spent doing these different activities, we included time spent in their occupation as well as their own personal time spent in those sorts of activities. Most of the population was black, and about 65% were black, about 10% were Hispanic, and the rest white, mostly males. About half had smoked. About 73% of the population of 898 reported doing some restoration work. Okay. So there were some significant prevalences of respiratory symptoms. About a third reported dyspnea. About 37% reported new onset of sinus symptoms. We also asked specifically about episodes of fever and cough, absent infection. And this was a marker for toxic pneumonitis and potentially hypersensitivity pneumonitis. And you can see that almost a third of the population reported episodes of fever and cough. Some of these folks reported more than 10 episodes up to the point of interview. So this is one of the really common adverse respiratory effects that we saw in this population. About 13% had reported having asthma ever, and in particular, which we were interested in especially, was new onset asthma after Katrina. And for that we had, our baseline was 784 individuals who had never had asthma before. And so out of that 784, about 4.3% of development of new onset asthma after Katrina. It works out to be around 35 people or so. Okay. 4% reported developing pneumonia after Katrina. And COPD about 6%. And then LLN, less than LLN, that's the lower limit of normal for spirometry, lung function. And so this is basically the 5th percentile or below. So if your lung function was below 5% of the population, in the lowest 5% of the population, that would put you in this category of below lower limit of normal. Based on the definition of lower limit of normal, we would expect 5% to show up in a large enough sample. And so these numbers appear elevated, but it doesn't take into account the smoking effect. And so if you take out smoking, it turns out the percentages of being below lower limit of normal were about what we would expect. A little bit lower, but not dramatically so. Okay. Now, in terms of the exposure assessment, let me talk a little bit about this with you all, share what we did. Again, our main problem here was that we had this 2-year window after Katrina where we weren't able to collect any data because of the mechanics of the grant process. So we took 3 approaches to trying to doing the exposure assessment, incorporating and integrating these 3 approaches. First thing we did, of course, as I already mentioned, is administered a questionnaire survey to the workers, asking them about how much time they spent doing these various restoration work activities after Katrina, up to the time of interview. And again, we included both occupational restoration work and personal or avocational restoration or remediation work. We also asked them at that time about use of personal protective equipment, or specifically respiratory protective equipment. And the second component of the exposure assessment, as it turned out, while we weren't able to collect any actual quantitative data in that 2-year period, OSHA got into the area right after Katrina and did extensive sampling of restoration workers. And that data is available online. It's in the public domain. And so we accessed that database from OSHA. They started sampling, collecting data in, I believe it was September of 2005, and continued to monitor restoration workers and other workers in the area through August 2006, 1 year after Hurricane Katrina. OSHA, in this process, OSHA monitored many different kinds of exposures, chemical toxicants, specific chemical toxicants, as well as more generic chemical toxicants. And for our purposes, we focused on the particulate matter exposure information, and OSHA sampled for both respirable dust and total dust. Now, we had decided, for the purposes of our study, we wanted to focus on the thoracic fraction of airborne particulate matter. The thoracic fraction of dust is that fraction of dust that penetrates past the head airways and enters the trachea and bronchi and lower, and is appropriate when you're interested in any respiratory diseases affecting the mid-airways down into the gas exchange region. And so we felt that was, for our purposes, the most appropriate size fraction to focus on. And there was also a practical issue involved, and that was that we wanted to assay the dust samples we collected for endotoxin content and beta-glucan as markers of the gram-negative bacteria and mold. And we had concerns about, because we just weren't sure what the exposure levels were going to be like, we had concerns about the analytical sensitivity associated with those assays. And by collecting thoracic particulate matter, you wind up collecting more dust than you would if you focused on just, let's say, the respirable fraction. So there was a practical issue also involved. Well, because of that, we actually had to take the OSHA data and try to convert it into equivalent thoracic particulate matter measures. And I'll show you how we did that in a moment. And then the third component of the exposure assessment was actual air sampling that we conducted ourselves throughout the study, beginning in 2007. Personal sampling, supplemented with some area sampling as well. And again, we were collecting thoracic particulate matter and assaying these samples for endotoxin and beta-glucan. So this is the sort of a summary of the results that we found from the survey of restoration work activity reported by the cohort. Again, about 73% of the cohort reported doing some restoration work. That's 655 people. And of those 655 people, about 80% reported using some respiratory protective equipment during the restoration work. And the frequency of use and the type of RPE varied greatly, as you might expect. Some of these people were in formal respiratory protection programs. Those people who were employed at the 3 major institutions, and if they were in facilities services, they were probably in a respiratory protection program. The construction workers, no, forget about it. People who were just working on their own homes, no, they didn't have any formal respiratory protection program either. I would say most of these folks probably were using filtering face pieces once they became available. I don't know if you recall, it's been 10 years now, but right after Katrina, there was a major shortage of filtering face pieces because they were a hot item, to say the least. And so in many cases, it wasn't well into toward the end of the year in 2005 that people were able to get their hands on these 3M filtering face pieces and other brands. Some use of tight-fitting cartridge respirators as well. Anyway, looking at the reported time spent in these restoration activities, for the 5 restoration activities that we had broken this down into, what you see is median times, 620 hours in any restoration work activity combined up to the point of interview. Most of this was up to 2007 or in some cases 2008 for initial visit or participation in the study. And you see also, if you look at the ranges, some extraordinarily high values. 11,750 hours in a few years. We had repeated anecdotal reports from these people that many of them were working 16-hour days, sometimes 7 days a week. And so they were accumulating the exposure time early on in the process, and then that began to slack off over time. Okay? But the point is the majority of their restoration work time was during the high exposure periods, shortly after Katrina. Okay? We didn't see too many individuals doing sewer line and water line repair. Most doing demolition and rip out, and quite a bit doing trash removal, trash management, and landscape restoration. A few doing mold remediation. That was mostly the custodial and janitorial workers. The second component of the exposure assessment strategy was the use of the OSHA exposure database. Again, the data was collected from the fall of 2005 through 2006. And OSHA monitored workers in Louisiana, Mississippi, Alabama, and Florida, doing both personal and area sampling for total and respirable dust, using some direct reading instruments as well as integrated filter samples. There were about a little over 1,000 measurements of total dust and about 416 measurements of respirable dust. Most of the samples were collected in Louisiana, 730, and Mississippi, 726, less in Florida and Alabama. When we used this data, we actually only used Louisiana data. And the reason for that is that the situation in Louisiana was fundamentally different from the other areas. Especially Mississippi, which also had quite a bit of data. Mississippi generally is above sea level. And so when the tidal surge went into the coast, the Gulf Coast of Mississippi, and the storm passed, that water drained out rapidly. In New Orleans and other areas of southeast Louisiana, as I've already said, the water was in place for weeks before it was able to be pumped out. So it was fundamentally different. So because of that, we decided to just focus on the Louisiana data in this process. This shows all the OSHA data for total dust and respirable dust. Most of the measurements, were not particularly astounding. The median for total dust approaching 1 milligram per cubic meter. And the median for respirable dust approaching 1/10 of a milligram per cubic meter. The OSHA PELs for particles not otherwise classified is 15 for total dust. As you can see, there's only a few percent of samples overall that exceeded that PEL. And for respirable dust, 5 milligram per cubic meter. Again, only a few percent overall exceeded those OSHA guidelines. And this is the Louisiana data, OSHA data, broken down by year, 2005 or 2006, and the restoration work activity. Okay. There's a lot of data here, but let me just point out a couple of important points. The first thing is that in 2005, the respirable fraction was a significant part of the total dust. Okay? 2.8 versus 4.1. So more than half of the total dust was in the respirable fraction for demolition activities in 2005. And then in 2006, you see that changed. And it dropped to about 1/10 of the total dust. Again, I think this was related to a couple of issues. One is the sediment that was everywhere. By the end of 2005, most of that was gone, been removed or been washed away by rain and so forth. And the other thing that occurred is that right after Katrina, the municipal water system in the New Orleans metropolitan area was inoperable for a long period of time. And as repairs started to be accomplished and the water system came back online, we started to see more and more use of water spray as an engineering control for dust suppression. And that really started to be common when we were into 2006. Okay. The other thing we see overall, again, is that in any case, the levels dropped pretty significantly from 2005 to 2006. And again, it's for the same exact reasons that, that we saw the change in the respirable fraction of total dust. Overall, the highest exposures were associated with demolition and trash management. Exposures for sewer and water line repair and landscape restoration were considerably lower overall. And as it turns out, we couldn't identify any activities in the OSHA database that were actually clearly mold remediation. So we didn't have any data from OSHA on that particular activity. Okay. As I said, we had to convert the OSHA data to thoracic particulate matter in order to use in our analyses. And what we did is we scoured the literature to find some data available to us in which thoracic and respirable and total dust samples were collected simultaneously so that we could develop conversion equations to convert total and respirable dust into thoracic equivalent. And there were two data sources that we identified. One was from a paper describing sampling in limestone quarry and coal preparation activities. A second paper in industrial wood processing. And then we went out and did a few samples of our own, what we could, in a demolition operation of an abandoned school building, okay, where we collected the three fractions simultaneously. So we ran multivariable regression models on each of these three data sets. Model, as you see here, thoracic particulate matter would be equal to coefficient beta 1 times the respirable measurement plus beta 2 times the total measurement. And these are the values of the coefficients that we got. Fairly consistent across the three models and high correlation coefficients. We did a statistical analysis of these three models and found that they were not significantly different. Obviously, we had concerns about, well, how well would limestone quarry and coal preparation pertain to restoration work. And so the statistical analysis sort of allayed our reservations about doing this process. This is what the predictive models looked like in performance in comparison to the actual thoracic measurements that were taken. This is the predicted on the y-axis. So when we applied these models to the OSHA data, we applied each model separately to the data and then took the overall average equivalent thoracic particulate matter from the models. Okay? And so you can see for thoracic particulate matter estimated for the demolition operation in 2005, average 5.8 milligram per cubic meter from the OSHA data, and then it dropped by over an order of magnitude into 2006. Likewise for trash management, fairly high in the first year, 2005, 4.2, and then it dropped by almost an order of magnitude in 2006. The other activities showed considerably lower exposure levels. The third component of the exposure assessment was our own sampling and monitoring. Again, we used the BGI GK 2.69 cyclone to collect thoracic particulate matter, personal sampling mode. We collected about 775 samples over the course of the study. Target sampling duration of 6 hours. These were analyzed gravimetrically for thoracic particles, and then about a quarter of the samples were sent off to University of Iowa for determination of endotoxin and beta glucan. Okay, and so this is what the thoracic particulate matter average exposures looked like across the entire period of interest, 2005 to 2012, for the 5 restoration work activities and the other category. And what we see obviously is a dramatic drop from 2005 on, particularly for the demolition and trash management operations. Okay? By the time we were into 2006, 2007, generally exposure levels were well less than a milligram per cubic meter on average. In 2005, trash management and demolition, around 4 to 6 milligram per cubic meter on average, thoracic particulate matter. Just for comparison purposes, we wanted to get a sense of the importance of these levels of exposure. There are no exposure guidelines for thoracic particulate matter, unfortunately. But there was, in 1995, a TLV for particulate matter, for respirable fraction, and for total dust. 3 milligram per cubic meter for respirable and 10 milligram per cubic meter for total dust. So we took that information, the 3 and the 10, and put it back into our predictive models to convert respirable and total dust to thoracic particles. In doing that, came up with a sort of an equivalent TLV for thoracic particles of 8 milligram per cubic meter. And so you can see that in 2005, the average exposures were approaching that synthesized TLV, if you will. And remember, this is the average exposures, the arithmetic average. The data was log normal, and there were many, many individual exposures, undoubtedly, that far exceeded this 8 milligram per cubic meter level. This shows the endotoxin exposures. And again, in 2005, on average, levels in demolition and trash management approaching the 250 EU per cubic meter range, on average. Again, within that average, there would have been excursions much higher than that. We do have an occupational exposure limit for endotoxin that was suggested by the Health Council of the Netherlands, and that's a level of 90 EUs per cubic meter. So demolition and trash management in the first year were well above, on average, that occupational exposure limit of 90 endotoxin units per cubic meter. But in 2006, it dropped dramatically again and continued to drop through the course of the study, especially for some of these activities. Likewise, for glucan, the initial glucan estimated exposures on average, very high, 80 to about 120 microgram per cubic meter for demolition and trash management. For comparison, some work by Peter Thorne and his people looking at the Cedar River flood event in Iowa a few years ago. They were seeing endotoxin levels less than about 20 microgram per cubic meter. So these levels that we estimate were quite a bit higher than that. All right, now let's look at the outcomes of the health analysis. We looked at various symptoms, and this table shows you those symptoms or conditions that were statistically elevated for those who did restoration work versus those who did none, okay? And so we saw statistical elevations in prevalence for fever and cough, the marker of toxic pneumonitis, sinusitis, dyspnea, and importantly, new onset asthma, okay? So for fever and cough, we saw an elevated prevalence rate ratio of 1.6 among never smokers, but no statistical elevation in current smokers. Okay? Likewise, in sinusitis, a statistical elevation in prevalence for never smokers only. Dyspnea, only a statistical elevation for the overall population. And then for new onset asthma, once again, a statistical elevation only for never smokers. PRR of 9.2 is pretty high, okay? Even though the confidence interval is pretty large because, you know, the sample size was small. I mean, we only had 35 or so new onset asthma cases out of the population. There was no statistical elevation for pneumonia, COPD, or being below lower limit of normal. Okay? The other thing we did is we looked at the same symptom complexes as a function of exposure dose in some fashion. We looked at, graphically at least, the association of the prevalence of these symptoms with quartiles of restoration work time. Okay? And you can see for fever and cough, I mean, there's a pretty obvious and systematic increase in prevalence with increasing time spent in restoration work. The blue bar, the first bar, is the controls, those who reported doing no restoration work. Even in those who did no restoration work, we're seeing prevalences of about 20% of fever and cough. Yeah. People living in New Orleans at this time were being exposed whether you were doing restoration work or not. So, you know, that was the situation, I think. Likewise, sinusitis, dyspnea, and asthma. The asthma data is sort of up and down. That's, again, because of the small sample size, but also, I think, because of, you know, sort of a healthy worker effect. Somebody who develops new onset asthma is likely to stop doing demolition and trash management work because they probably couldn't tolerate it. And so, you know, because of that, the exposure, restoration work times would have been skewed towards the lower ends in the new asthma group. We also did logistic regression to analyze these trends quantitatively with cumulative exposure to thoracic particulate matter. So this is prevalence odds ratios per 1,000 milligram per cubic meter hours of exposure dose. And again, fever and cough, significant for never smokers, sinusitis, significant in current or ex-smokers, dyspnea, significant for never smokers, and asthma, once again, statistically elevated for never smokers. And for the lung function measurements, overall the population showed at baseline a lower predicted, percent predicted lung function than expected. In a healthy population, the percent predicted would have been 100% for everyone. Generally, the average percent predicted for FEV1, FVC, the ratio, and FEF 25/75 mostly were suppressed a little bit below 100%. Of course, you'd expect to see that in this ever smokers, but even in the never smokers for FEV1 and FVC, overall, on average at least, the lung function of the population was a bit lower than expected. And this is statistically different from 100%. We did robust statistical analyses of our various measures of exposure with lung function over time, as well as initial lung function at first interview. None of those analyses showed any statistically relatable correlation with any exposure measure. What we did see for FEV1 and for FVC, both level, okay, at baseline, a positive correlation with exposure. That is, the lung functions were a bit higher for those who had exposure versus those who didn't. And again, I think that's evidence of a healthy worker effect. Okay? People who had respiratory issues would not have done this restoration work in the first place, or would have stopped doing, more likely to have stopped doing restoration work. So I think the longitudinal analysis of lung function is being confounded by this healthy worker effect. Okay? So, in summary, in conclusions then, we saw again about 73% of the population reported doing some restoration work. The work was characterized by extraordinarily long hours spent doing this, especially in the immediate time period after Hurricane Katrina. Dust and endotoxin exposure levels in 2005 for demolition and trash management exceeded exposure guidelines. Glucan exposures were also elevated, although we don't have an exposure guideline to compare those to. Those exposures decreased dramatically after 2005 by more than, generally, more than an order of magnitude. We saw significant increases in prevalence of fever and cough, again, the indicator of toxic pneumonitis. sinus symptoms, dyspnea, and importantly, new onset asthma. And those prevalences increased with increasing time spent in restoration work and increasing cumulative exposure to thoracic particulate matter. Lung function overall was a bit depressed in the cohort, but we couldn't relate that to any particular measure of exposure, and is likely being confounded by a healthy worker effect. So in conclusion, the results of our study, I think, lend additional support to the concerns associated with exposure to moldy and damp environments, in particular in this context of flood restoration work where the exposures are astronomically high, at least they were in this Katrina event. And we need to focus on, I think, having mechanisms in place to help manage exposures in these sorts of events. It's an entirely chaotic environment, but those institutions and organizations that have some authority, like FEMA, NIOSH, OSHA, it would be beneficial to have plans and systems in place to help provide restoration workers in these environments with guidance on exposure management and use of personal protective equipment, and the use of engineering controls to try to manage the dust exposures, including things as simple as using water spray suppression of the dust. Okay. I'd like to acknowledge my co-investigators. Henry Glenmeyer was the principal investigator of this study, a colleague of mine in the pulmonary diseases section of the medical school. Hank passed away in 2009, about 2 years after the study began, and then I took over management of the study to its completion. And then the University of Iowa folks, Peter Thorne and Nirvana Metwally, did the endotoxin and glucan assays for us. And of course, I'd like to acknowledge NIOSH for their support of this research. So thank you very much.